All right, well, it is officially 12 o'clock, so we will get our webinar started. Thank you so much for all the participants who are jumping on this really important webinar, and a very special thanks to Rogers Behavioral Health for presenting for us and just providing all of their expertise. My name is Erin Teggy. I'm with the Glenview Northbrook Coalition for Youth, and we focus on substance use prevention among our youth throughout Northbrook and Glenview. And we very much know that adolescent substance use is often very impacted by mental health, specifically, depression and anxiety and things of that nature. So we're really excited to be bringing this really important topic to the community. And we are so thrilled for the experts from Rogers who I'll be introducing shortly. So a couple housekeeping things to go through. This webinar is being recorded and will be available on our GNCY website, as well as our YouTube channel. If you do have questions throughout the presentation, please use the Q&A function and to submit questions that way. We'll be reviewing them at the end, so hopefully we'll have time to get to them all. We will also be sending out an email with the PowerPoint presentation, as well as some other stuff from today, like some community resources. We'll be sending that out to all of you probably tomorrow, realistically. So you'll have access to the slides, so you don't have to try and remember everything that we're going to talk about. And then hopefully you guys will complete a short survey at the end of the webinar. I'll send out that link as well, just so we know that we can keep doing good work for our community, and if there's other topics that you guys in our community want, make sure that we're covering those topics. So to introduce our two presenters from Rogers Behavioral Health, we have Julia McAndrews, and she is a marriage and family therapist with Rogers Behavioral Health. She received her master's in marriage and family therapy at Edgewood College and completed her training in community mental health and hospital systems. Julia currently holds the role of lead child and adolescent family therapist at Rogers Behavioral Health, where she supports the mood and anxiety and autism spectrum disorders program, the child and adolescent OCD and anxiety recovery program, and the depression recovery program. And one of Julia's professional passions is connecting with the community to reduce the stigma of mental health and provide education on how to access high quality treatment. And then we also have Dr. Paula Young, who is a licensed clinical psychologist who oversees the clinical programming throughout Rogers, Chicago, Skokie, and Hinsdale programs. She received her Doctor of Philosophy degree in psychology from Rosalind Franklin University of Health Sciences and the Chicago Medical School, and completed her internship at the Medical College of Pennsylvania and a postdoctoral fellowship at the University of Pennsylvania. Dr. Young has an extensive clinical teaching and research experience in the areas of depression and anxiety disorders. She has participated in multiple NIH-funded treatment studies of the treatment of depression and has presented in numerous clinical and academic audiences across the country. She is a diplomat of the Academy of Cognitive Therapy and a fellow of the Association of Behavioral and Cognitive Therapies and a native of Northbrook. So we are so grateful to have such experts presenting on this topic. And so I am going to let them take it away from here and get on with the presentation.
Thank you, Erin. See if I can figure out how to share a screen. Here we go. I think this is it. Is it working? Okay. Let's do, oh, hang on, what? That one. There we go. Thank you everybody for coming this afternoon. And I think we've got a really important topic to talk about. I think when we originally talked with the GNCY several months ago, we had talked about doing a presentation on depression. And the main reason we were going to do that is that at Rogers, we had noticed that over the course of the, the shutdown and the pandemic, that we were getting more and more people coming in looking for treatment for depression. and their depressions were worse than we had seen, right? It's more severity going on in the depression and more depression. We think it's time that we start talking about this. And that was before the tragic suicide that happened in the community. So since then, we've decided that in addition to talking about depression, we are going to talk about a little bit about how suicidal ideation fits into that. I know that people have had plenty of kind of outreach and experiences talking about depression, but I still think that there's some concern in the community about what's happening with our teenagers. So we're going to address that today. Our agenda includes kind of what is depression, knowing your signs and symptoms, what's it going to look like if your kids have it, how does suicidal ideation fit in with depression. We're going to talk a little bit about how we treat depression, and then we're going to talk about family involvement, how you can get involved. And then Erin had mentioned that people are interested in finding out, how do we prevent it? Can we do something ahead of time so that we just reduce the risk of it? So we're going to talk a little bit about that, and then we'll open things up for questions. This is from, it's a blog called Hyperbole and a Half. And I really like it. I don't know if you can see, we've got our little person that says, what if the entire future is full of only horrible, boring things? And right, they're kind of slumping against the wall saying that would be too many. And in case you can't see it, I will read it to you. It says, at first, I'd try to explain that it's not really negativity or sadness anymore. It's just this detached, meaningless fog where you can't feel anything about anything, even the things you love, even fun things. And I have to move my screen. And you're horribly bored and lonely. But since you've lost your ability, sorry, I'm going to move this so I can see it. Horribly bored and lonely, but since you've lost your ability to connect with any of the things that would normally make you feel less bored and lonely, you're stuck in the boring, lonely, meaningless void without anything to distract you from how boring, lonely, and meaningless it is. And I like this because it reminds me and everybody who reads it that depression isn't just sadness, or it's not just a sad mood. I mean, people get passing depressed moods, but that's not what we're talking about when we're talking about depressive disorder. And here, depression is an illness, not a weakness. This was the slogan from, I think it was the first Depression Awareness Week that I ever participated back in the early 90s. And this was their slogan. Because a lot of times people historically have thought about, oh, depression is, you're just in a sad mood, right? Or you're just lazy and we could fix it if you just worked harder, you did more things. Or it's just moodiness, or it's a character flaw, or, somebody's trying to manipulate me by saying they can't do stuff because they're depressed. Like it's an excuse, or that it's all in your head. And if you just thought better things, that you'd feel better. And it's not any of those things. But what is it? We're going to get to. But before I do, I want to bridge it. I want to bridge our gap by talking about stigma, right? So if we think, and kind of historically we have, things are changing. They've been changing over the last 20 years from thinking about it as kids don't get depression. That was a popular one, or kids don't have anxiety disorders. But as the research has gotten more sophisticated and we're finding it happening in youth more and more, we've been studying it more and starting to have earlier interventions. Part of what happens is if we think about depression as being something that somebody's doing because they're lazy or they're making excuses, there's some stigma that comes with it. And we can talk about two types. There's the self-stigma that the person with depression has, right? And they are concerned about even the possibility of getting that diagnosis or saying that they have depression because of all that, the stigma from that last slide that I just mentioned. They're also worried about, what are other people going to think if I say that I have depression? So what are my friends going to think, or my teachers, or what is if I go and ask for help? what are they going to say? And then those two types of stigma, right? Worried about what does it mean about me and what are other people going to think? Those are the two huge barriers that we have to break down so that people can get treatment. Because when people have they're thinking about stigma and depression, they don't reach out, they don't share, they don't get help. And it's just this kind of belief that people have about their own depression that can stop them from getting the help they need. Why do we stigmatize depression? Well, the first one is that it has like usually non-physical symptoms, right? So if somebody broke their leg and they were on crutches and they had a cast on, you can see that that person's having trouble. But mental illness doesn't look that way, right? It's not easy to spot. People often misinterpret the symptoms of depression in the same way that I just mentioned, right? Oh, you're just tired, or you're lazy, or right, making excuses. And plus that person's own response to their depression, which is kind of trying to hide it or being embarrassed by it or not wanting to share it. There's also a lack of awareness of depression. That's part of why we really wanted to talk to you today, is to give you an awareness, to let you know what the research says and what it looks like in the clinic, so that you know what to look for and you know how to talk about it. And then we've got all sorts of stuff in the media where a lot of it is sort of sensationalized, or it's really dramatized to make, I don't know, TV or movies more interesting. But the media portrayal of depression often doesn't look so great. It looks pretty catastrophic, or it's terrible. And that does something to make the media more interesting, but it doesn't help us understand and be able to reduce the stigma. How are we going to fight it? We're going to do today. We're going to educate yourself about depression. So as you know more about it, you know what to look for. You start to know how to talk about it. We can be more compassionate toward ourselves. If you've got your own kind of depression, being more compassionate about having depression, or being compassionate toward others, and then sharing awareness with each other and advocating for getting awareness, prevention, treatment. And that is part of our goal for our talk today. Okay, so I've been talking about what it isn't. Now I'm going to talk about what it is. And this is, sometimes you'll hear people say, oh, I have a clinical depression. In the Diagnostic and Statistical Manual, 5th version, they call it a major depressive episode. There's a bunch of varieties of depression, but I'm going to talk about the big one, sometimes called MDD or MDE. Major depressive episode is the collection of symptoms. And here's something that surprises people, is that it only takes, 2 weeks. 2 weeks where it's most of the day, nearly every day. So when I say most of the day, nearly every day, I'm thinking if you'd say, 5 days out of the week, you have these most of the day, that qualifies as a clinical depression. And I'll say in my outpatient practice, people are surprised when I ask them the question, and I say, that's depression. It's, they come in because they say they have stress at work, but then I ask the questions and they meet a diagnostic criteria. So it doesn't have to be like how you see it on television, where somebody's in a bathrobe all day. There are people who have major depression who get up and go to work every day and come home and take care of their kids and manage a household. And they also have major depression. So the bathrobe criteria is kind of an extreme. You can still be a functional person with depression, although it's going to be really hard to function. So we have a 2-week period where you get 5 or more. So you get to choose from these. But the first one has to be either a depressed mood that lasts most of the day, nearly every day. In kids, this can show up not so much as depression, but as an irritability, or a loss or interest and pleasure in most of your usual activities. So that would be, hanging out with your friends, or playing your musical instrument, or doing school things, or doing extracurriculars. So that's kind of loss, or the feeling that you have to push yourself to do those things. In addition to one of those, there are some additional symptoms, and they include a change in weight. And here you can either have a weight gain or a weight loss. So that's about 5% of your body weight in 1 month. So it would happen kind of fast. Or just a change of appetite. So sometimes people end up eating a lot more. Sometimes they eat a lot less. It can go either way. The next one is trouble sleeping. Insomnia is that you can't sleep. Either you have trouble falling asleep, or you can fall asleep, but you're waking up in the middle of the night and getting stuck awake, or you're waking up too early in the morning and you can't go back to sleep. So, an hour or so before your alarm. And you can use kind of an 8 hours as a measure. So insomnia is much less than 8 hours. Hypersomnia is more than 8 hours. The next one is psychomotor agitation or retardation. These sound kind of weird, so I'll break them down. The psychomotor agitation just means that somebody is fidgety, right? So, pulling at their hair, twisting their hair, biting their nails, or picking their skin, or they can't sit still, or they're kind of shaking their leg. And the psychomotor retardation just means that somebody is moving slower than usual. So they're talking slower. People will say that their voices get smaller and kind of far away and lighter. But there's a long time. So if you ask somebody a question, there's a long pause before they answer. Families tell me that they can hear this on the phone, right? That they call their son or daughter and it takes them a long time to answer questions on the phone. These would be visible to the family, probably more so than to the patient. The next one is fatigue or loss of energy nearly every day. A little hard with teenagers, but usually teenagers can kind of rally. This is pretty much every day that they're reporting that they're either tired, exhausted, or they have much less energy than they used to. The next one is either feelings of worthlessness. And this isn't just low self-esteem. This is actually, people will say, feeling worthless, or excessive guilt. Now, this isn't just feeling guilty. This is kind of excessive guilt. And I think a good example of that is we had a patient here who was talking about, their computer didn't work, right? And then they were frustrated because their computer didn't work. Well, that makes sense. But then feeling guilty because they shouldn't be frustrated because their computer didn't work because there are people, who are starving. That's the kind of excessive guilt. And then just kind of ruminating about that guilt. Another one is either difficulty concentrating or making decisions. Difficulty concentrating would be about, just being able to get through a TV show and be able to pay attention the whole time without kind of losing track of it, or reading sort of an easy book. Making decisions, this isn't about where am I going to go to college or what am I going to be as a career. This is, should I get dressed first or eat breakfast first? Or which cereal should I eat? They are little everyday decisions that get really hard to make. And then the last one is recurrent thoughts of death or suicide. So thoughts of death is just, all of these represent a change from how the person used to behave, right? So all of a sudden, if somebody starts thinking a lot about death, and this is maybe doesn't really include if there was a family member or a friend who died, but all of a sudden starting to think about what would it be like to be dead, or what happens when you die, I don't think life is worth living. I think it would be easier if I wasn't here. I think maybe I should be dead, or I'm going to do something to kill myself, right? So any of those count here, and that doesn't have to be present every day. It only has to be present once for it to count. So that's what our major depressive episode looks like. There's lots of different combinations. So each one of those things that I talked about, there was an either or, right? Worthlessness or guilt, insomnia or hypersomnia. So two kids might not have the same symptoms, but they'll both meet criteria for major depression. So again, I just kind of want to get people off the idea that it looks like you're laying in bed all day in your bathrobe. Not necessarily, right? So we can have, right, one kid who's eating more and sleeping more and feeling guilty, and another kid who's eating less, losing weight, not sleeping, and feeling worthless. And they both, right? And then one is agitated and the other one's moving slowly. And they'll both meet criteria for a major depressive episode. In kids, right, when we're talking about adolescents, they're much less likely to report feeling depressed and more likely to have mood lability, which just means they're kind of moody, right? So they're, right, either they're sad and then they're anxious and then they're hopeless and then they're angry and then they're, right, but then they're kind of happy, and it moves around a lot, but they spend a lot of time in those negative moods or just straight up irritability. In kids, we're also more likely to see anger outbursts. Kids and older folks, actually, when they've got the depression, it often shows up as bodily aches and pains, stomach aches, and other health complaints. And in kids, you're likely to see social withdrawal. So they stop interacting with their friends or spending time with friends or doing or spending time with family. Here's the prevalence. Here's how common it is, right? So I'm not sure if anybody can see this, but I'll read out the important parts. Overall, if we look at 12 to 17-year-olds, overall, in the past year, when they did this study in 2017, 13% of the kids met criteria for one of these major depressive episodes. And that's split out 20% of females and almost 7% of males. So it's more common in females than males after puberty. As time goes on, the numbers go up until we hit some big numbers around 17, 15, 16, 17 are these higher ages, 15, 16, 17. And here we're getting 17%, 17%, and 18%, almost 19%. Hispanics and whites have about the same. African Americans a little bit lower. Over here, this number, 16.9, is for kids who identify as having two or more race or ethnicities. So it's a little higher in biracial kids. What does it do? So impairment just means how much does this depression impact your life as far as academic performance, social performance, enjoyment of activities. So in these, in the same kids, when they do this study, about 70% are categorized as having severe impairment, right? About a third don't have severe impairment, but 70% of them did. So it's not just that it's prevalent, but that it really is kind of interfering in kids making it through their regular developmental milestones and doing well at school and having good social relationships. As far as treatment, data's right, it's a little dusty from 2017, but this is important. When we look at who's getting treatment for their depression, about 2.5% are getting medication only. Almost 18% are seeing a health professional, and here I'm thinking health professional is therapist plus medication. About 20% are getting therapy only, and that's all good. And it's this side that bothers me, which is 60% of the kids aren't getting any treatment. So that's an area that we really want to improve on. I mentioned sex differences a little bit earlier. Turns out if we're looking at kids and we're getting the counting up the cases of people who have depression before puberty, it's about the same, 1-to-1 boys and girls, maybe slightly higher for the males. But then once puberty hits, all of a sudden our females are at risk, right? So they're almost at twice the risk of the males after the onset of puberty. What is that about? We've got some hypotheses. So one of them is that for girls, there's a greater emotional intensity. And for those of you who have girls, you might recognize this, greater emotional intensity and reactivity during puberty. There was one study where they were looking at, they ask kids to look at faces, a whole bunch of different faces, and some have expressions on them and some don't. And girls are picking up on facial expressions and negative facial expressions much easier, which makes them more sensitive to any sort of criticism or negativity. They may be more susceptible to having more negative emotions because of that. There's hormonal changes that happen around puberty for the girls. We also have negative psychological and social consequences of puberty, which is body dissatisfaction. So as girls go through puberty and they have normal body changes, all of a sudden the rates of body dissatisfaction ramp up, and this happens more for females than males. There are peer stressors. So as you get into junior high and high school, the focus and the shift for the kids shifts from the family, and the peers become much more important. And the kind of peer bullying and peer victimization for females is more stressful. Adolescent girls also have been shown to do more rumination, and what we're looking at as far as rumination is when you sit with your thoughts going over and over and over all the negative things and the bad things that have happened. Girls are much more likely to do that than boys, adolescent boys, and more likely to do so after puberty. So these things can put the girls at a higher risk. How prevalent is it? Well, if we're looking at the adult population at any given time, it's about 5%. So 5 out of 100 people. At any given time, 2 to 5% are in an episode. So 5% in the past year, 2 to 5 at any given time. In adults, 2 to 1 females to males. Children, it's a 1-to-1 ratio. We got good news and bad news with what's the kind of the prognosis and the course. How does it work? So depression is a relapsing and remitting illness, which means that it goes away, but then it can come back. So about half the cases will get better within a year, kind of on their own. Whether you treated them or not, about half will, but half won't, right? So half of the cases will continue or maybe get a little bit better, but sort of linger in the background. There is a chronic type of depression, which lasts more than 2 years, and about 10% of the episodes can be chronic. And for each episode of depression, here's the thing that I want to make sure that our patients and our families understand, is that each episode of depression puts you at risk to have another one. So the average interval between episodes is about 5 years, but that interval can get smaller with the more depressions that you have. So the first time that you have a depression, your likelihood of having a second one is higher than for the guy next to you who didn't have one. Often these things start most commonly in the mid-20s. They can happen in old age, and they can also happen in adolescence. And today we're going to talk about the ones that start in adolescence. The onset tends to be gradual. It sneaks up on you. When we talk in our clinic about our patients who have OCD, some people can tell me the day that their obsessive compulsive disorder started. I remember it was this day. People with depression don't do that. They can't do that because it sneaks up on people slowly. And it sneaks up so slowly that sometimes that you don't recognize that you're necessarily in it because it took a while for it to develop. Often the first episodes of depression are precipitated by a stressful life event. So any kind of stressful life event here will do, changing schools or getting bullied or having family discord or having trouble in school. And it's usually kind of a big stressful life event. But remember, I just said that the more you have, the more you can have. And so what happens is people get, in some ways, they get sensitized to it so that in the beginning, people can kind of point to a stressful event or a stressful period of time that happened before the depression. As people have more and more depressions in their lifetime, the stressor needed to kick it off becomes smaller also, right? So that risk gets riskier over time if you don't interrupt the cycle. That's part of what we want to talk about today, is catching it early and interrupting that cycle. Some of our risk factors include family history, right? So that there's some evidence that this is, right, that this can be hereditary or genetic. So if we've got a family history of depression or bipolar disorder or suicide-related behaviors or substance abuse or any other psychiatric illness, that can be an increased risk factor for somebody developing depression. Like I mentioned, significant psychosocial stressors, including family crises, physical or sexual abuse, neglect or other trauma, having a medical illness or frequent, bodily complaints or pain, and foster care and adoption can also count as one of those stressors. As far as professional treatment goes, because I know I've been talking to some families and they've tried a bunch of things and this didn't work and that didn't work and maybe we should try, this treatment or that treatment. And they usually have a talk about, what are they called? Evidence-based treatments. So I'm going to talk about those. What's an evidence-based treatment? The American Psychological Association has a way of determining whether a treatment has been shown to be effective. And so what they do is they go through the literature and they look for something called a randomized control trial, which just means you get a bunch of kids with depression. Some kids get this treatment, some kids get that treatment. They randomize them. They don't ask. They just say, you get this group and you get that group. And then they do the treatment and then they compare the outcomes. So if you have several of those from different places and they all give you the same result, so they all say, ooh, this therapy works, right? It's worked in 5 different studies in different places. Then we have some databases to say, ooh, we think this one is effective. And the other ones that aren't quite as good don't get listed as being an evidence-based treatment. When we look for evidence-based treatments of depression in adolescents, there are only 3. And one of them is cognitive behavior therapy. And that is a recommended therapy by the APA. The other one is interpersonal psychotherapy for adolescents. That's another recommended one. And then as far as medications goes, fluoxetine, I think also known as Prozac, is the recommended treatment. Now, there are some other ones: family therapy, problem-solving therapy, psychodynamic therapy, supportive therapy, behavior therapy, cognitive therapy. Wait, didn't I just mention those? They're slightly different than cognitive behavioral therapy and other medications. They don't say that they don't work. What they do say is that we don't have enough. There aren't enough research trials that all kind of coalesce and say the same information. So I think the take home from this is, if you've got an adolescent with depression and you're saying, well, none of the treatments worked, I would direct people first to go to the blue bars, to the things that we know are recommended: cognitive behavior therapy, interpersonal psychotherapy, the Prozac. And to make sure that you've got somebody who is experienced in treating depression, to make sure that you've got an adequate dose of that. And by dose, one of the things that I do want to mention, because Julie and I work at a place that isn't your regular, just go to your outpatient therapist, right? We work at Rogers Behavioral Health where we do a higher level of care, which would be an intensive outpatient or a partial hospitalization, which means we do this thing not just for 1 or 2 sessions a week. These are half day and full day programs where we very much increase the dose of cognitive behavioral therapy. And we've got docs that are willing to work with the medication. So one of the things that didn't used to be so common is now something that I would encourage everybody to look around and see if your standard treatment isn't working, to consider a higher level of care where you go to a place that is Rogers or like Rogers that does cognitive behavioral therapy or interpersonal psychotherapy for adolescents that specializes in treating depression. That being said, plenty of people are getting all sorts of other treatments for depression, and you can, and all of these things that say that, right, there's not enough evidence doesn't mean that you cannot use them or that they're contraindicated. They don't say that you shouldn't use them. It just says that there's not enough evidence. So if you're working with your treatment team and your, psychiatrist says, well, I think, we should add this medicine or that medicine, and that's what the treatment team recommends, by all means, you can try it. But when you're looking at what are the ones that are recommended that have a proven track record, it's the 3 in the top blue box. And that's for adolescents. When we talk about adults, there's many more choices. And interestingly, when I went to look, we were talking about kids, many fewer choices because the research just isn't out there. Suicidal ideation is something that I wanted to talk about because we don't talk about it. And we don't talk about it. I'm sure lately people have been talking about it, but here's some interesting information. If we're looking at college students, and we're talking about suicidal ideation, remember it is a symptom of depression. If you ask that college students in the past year, about 10% will say that they had seriously considered attempting suicide in the past year. In high school, about 20% in the 1997 Youth Risk Behavior Surveillance Study, 20% had seriously considered an attempt in the past year. 16% had drawn up a plan. 2 to 10% had made an attempt. And again, this is more likely for girls to be considering suicide or plan. Hispanic students are more likely than white or African American students to consider a plan. And then does it start in high school? No, 12 to 16-year-olds, so it can start even younger. Between the ages of 12 and 13, girls, they followed girls 12 to 13, and they followed them until they were 14 to 15 years old. And thoughts of suicide in those kids doubled in that time frame. So that's that puberty risk that I was talking about earlier. In boys, the risk was reversed. They have fewer thoughts of suicide in that time. In one study of suicidal behavior in girls, about 15% had reported having suicidal thoughts or ideation. But then when they asked the parents were unaware. The parents don't know. So if you guys are surprised, that shouldn't be a surprise because parents don't know. And that's, again, part of why we want to talk about this and get people talking so parents can know. And when we're talking about the kids, who are they going to go and talk to when they start getting into adolescence and their focus shifts to their peers? They may be telling their peers, they may be talking to their friends about it, but they're not talking to their parents about it. So you are not alone. If you're like, hey, I didn't know about this. No, parents don't know because that's not who kids are going to. The suicide for females age 15 to 44, it's the second major cause of death. For males, it's the fourth major cause of death in that age range. Most suicidal thoughts go underreported or unreported and untreated. Again, it's the thing we're not talking about. And it doesn't discriminate. It doesn't matter, right, what your diagnosis is, what your age is, your gender, your race, or ethnicity. No, don't panic, right? So I said it, it's happening. Kids are thinking about it. And do you need to panic? No, you don't. but you need to be aware, right? So most people are not going to commit suicide. Kids are thinking about it. They're at increased risk, but it's not like there's a ticking time bomb in every household. Part of what we're doing today and what I think has been happening in the community is that there's increased discussion about it and talking about it, and that's going to help. And, the whole area in clinical research is, right, being able to predict who's at risk and what's going to happen. It is the most important problem that they have. There's much work being done to address this problem. So there is hope, and today we're starting that, stop the stigma and start talking about it.
Absolutely. I want to continue that and just kind of highlighting how we can break down some of the stigma and also really be thoughtful in understanding the risk, right? So there's a lot of different ways to look at suicidal thoughts, right? And we break those down into thoughts, which we don't necessarily have a lot of control over. Thoughts just come and go throughout the day, and that can be including suicidal thoughts, right? So this could be just kind of a wonder or an occurrence of, I wonder what it would be like to be dead or to not wake up. Then we can kind of transition into ideation, which is a bit different than thoughts. This is, having urges. Instead of just this thought popping into someone's head, this could be I'm spending time bringing this to my attention, right? I'm having urges to really think about this. Maybe I'm starting to fantasize about death or dying, fantasize what it might be like to not have, these triggers in my life, these stressors. Both are terrifically common. Both are terrifically common, and not necessarily an indicator that someone will commit suicide, but a good thing to be aware of. Right? When ideation comes, some people live with chronic ideation, right? So we do want to be aware that some people that are really struggling with suicidal thoughts and suicidal ideations may have these thoughts and live with them very effectively, right? When we start to get into greater risk is when there's plan or intent or an attempt, okay? So a plan, just like a plan for anything else, a time, a place is selected, and a method, okay? So you may notice or start to feel more concerned if a teenager or an adolescent is collecting medications, keeping these aside in a drawer, or you might notice sharps are missing, or certain questions are being asked about where to gather or contain these materials. Even with plan, a lot of people do have a plan, right? What triggers that to be more lethal is when there's intent. I want to now put this plan into action. It's not just in my head anymore. It's not just something that's a what if. I want to actually do this, okay? And this could mean that the day, the time it's selected, it's not just in our mind, it is with the hope of being carried out, and that can lead to an attempt, okay? Now, as people that care for adolescents that are working hard to make this speakable, we do want to highlight that these are questions you can ask, right? You can talk about this. You can say, I'm wondering, if you've had thoughts about wanting to die, right? Just getting a sense for if your teenager has had those thoughts, if your students have had those thoughts, if your neighbor has had those thoughts, it's okay. It still is stigmatized. So you might see them go, what, right? You're asking me that? And that's okay, right? We want to make it speakable, and putting the word out there, putting yourself out there as a compassionate person that's asking these questions doesn't put the idea in this other person's head, okay? If they say, goodness, yes, right? You can certainly lead into some of these other questions, right? Do you have an actual plan? Has there been some ways you've been thinking about doing this? Right? And again, that's not going to encourage your teen to try it. They're not going to go, great idea, mom. I'm going to grab, the laundry detergent or what have you. We're really just making it speakable. Okay. And as parents, you bring things up, and a lot of times you're going to get the eye roll. You're going to get, no, come on. But you have now made a culture in your home where this is not taboo, And if there's a crisis, you've made it possible, never guaranteed, but certainly more possible that your team can come and connect with you. And at very least, you've broken the stigma then in your home, and perhaps your team can do the same thing in their future home or in their classroom, or for a peer to say, yeah, okay, I know what to do. We can make this speakable. We can go and get support. So really, really highlighting it is okay to talk about this, even though it's difficult. Okay. So how do we talk about it? Right? What do we do? I know it's a big ask when talking about death and dying and suicide and depression, but stay calm. Right? Stay calm. One of the best ways you can actually execute staying calm is to practice this, which sounds, again, really goofy, but to be able to be present in the moment sometimes does require you calling up a loved one and saying, listen, I'm going to have this hard conversation with my daughter, my son. Can I just run through some of these questions so that you're noticing, am I tearful? Am I getting angry? What's going to come up for you? If you're lucky enough to have a therapist or want to seek help to just talk through how to do this, great. We always say at Rogers, practice makes routine. And though we hope that, needing to address this is not a routine in your home, we do know that it's a lot easier when the first time you're bringing these things up is not in that intense emotional moment. So practice, stay calm, use calm body language. And when or if your teen does say, yeah, I am having these thoughts, or I am really struggling, thank them for their honesty. It's so easy to be taken aback. Oh my gosh, are you serious? Wow, what can I do? We can problem solve later. There's resources. Right now, the objective is to listen. The objective is to be present. The objective is to remind your teen that this is a safe space, to just hear them out, right? And that's going to be a huge intervention in and of itself. If they're feeling acutely suicidal or having a tough time, you can do a skill together. We often say that thoughts are not fused with action, right? So if someone's having a thought, yeah, I'm really depressed, I'm really down, I do think I want to kill myself, that doesn't trigger an immediate action into suicide self or an attempt, right? It can lead to some really productive coping mechanisms, like checking your thoughts, taking a look at what's going on underneath the surface, doing some exercise or mindfulness. We're lucky enough to see that being taught in schools. Doing an enjoyable activity, taking a shower, brushing your teeth, right? These things can be teeny tiny, but if someone's not taking adequate care of themselves, jumpstarting that again can be really healing, right? When there's a mental health crisis, so this is when we're starting to look, oh goodness, the threat is here, right? My kid is very much struggling in the moment. Perhaps they're starting to show more signs of panic, or gosh, I just really can't do this. Again, the biggest thing, if you can take away anything from this, is stay calm. Stay calm. We as adults do carry that difficult responsibility to share our calm, right? And if we join the chaos, we're going to create a cycle of more chaos. Okay? It's a hard responsibility. It's not always done perfectly because we're humans. Okay? But staying calm, keeping a calm voice, asking your child, how can I help you right now? They may not know, and that's okay. Be present, use some short sentences, bring them back. You can remind them of facts, right? Give some affirmations. You're here, you're in the living room, you're with me. Let's take a deep breath. Maybe moving away so they can see the window or the door, not necessarily playing loud music, removing some stimulation, and just creating an environment where someone can come back, right? Come back to the reality, and we can start to unpack what's going on, but now they're safer. Okay. If there's immediate danger, again, we're reducing the stigma of seeking more support. Educators, parents, neighbors, loved ones care deeply, and they can't do everything alone, right? And so it's very scary to call 911. We talk this through with parents all the time, but you are setting a tone that I love you so much that I will get you the support and resources you need if there's immediate danger. So if property damage is occurring, if someone's threatening their life, if someone's holding a tool that could hurt them, say a knife or a firearm, right? Or has said, I have a plan, I'm going to take this medication, or they've done something, right? Take a breath, call 911, some key points to share, any diagnoses you're aware, any medications, psychiatric diagnoses. And if your child is aggressive at the moment, say that, hey, my child is having a mental health crisis. They're very dysregulated right now. They're acting unsafe. I need some support. My hope is that you can help me get them to a hospital, right? And if you don't have the words for that, it's okay. Start with calling 911. And gratefully, our first responders are getting more and more training in this, and we hope that that continues. If you need a safety skill, especially in that gap, if you're in immediate danger, you've called 911, or you just did some of those de-escalation techniques, we want to remember that a safety skill is really used to temporarily bring down the attention from that crisis. Okay, so it's not going to fix everything. It's not going to say, okay, well, you coped through this, your depression is gone. Right? However, it is going to say, hey, here's something we can do to survive this moment. You are showing yourself you can get through this. We are going to use our time, our tools to move through this distress. And in time, that practice, whether it's with a professional or you kind of used it in your home and things like this, it's going to build acceptance and tolerance of intense emotions. So just as Dr. Young shared, sometimes the triggers are really, really small as someone has struggled with depression for a prolonged period of time. Okay, now we're practicing confronting those things. We're practicing, using distress tolerance skills, and over time, hopefully those triggers feel a bit less heavy, right? And it's not a trigger at every turn. You definitely want to use these when someone you're seeing is experiencing intense emotions and are not able to tolerate them safely. So this is different than someone saying, I'm nervous for a test, or I am sad that my friend moved away, right? Those are difficult emotions. They're typical emotions. We want to normalize that. This is when someone is saying, I'm so distressed, I may harm myself. I'm so distressed, I feel like I can't keep myself safe. Or if there's so much emotion because a problem can't be solved immediately, all right, we're really nervous about, having to share this difficult news with a parent. We're not home right now. Child's upset, experiencing intense emotion. How can we bring them down and regulate? Because we're not going to be able to bring in a parent right now and just have this tough conversation together, right? So really, when there's any difficult, intense, unsafe situation, as a reminder, low distress is a part of life. It can be manageable. You can continue to do these activities that are day-to-day activities. You can continue to do schoolwork. It's normalized, normal emotions, right? When distress is moderate, this is when we want to start to use distress tolerance skills, just like we had mentioned, starting to get to that unsafe space, right? If distress is unmanageable, this is when it's going to teeter into being unsafe. We want to use distress tolerance skills, seek support. So if you notice if you're in the classroom, it's really, really starting to struggle, or they're leaving the classroom abruptly, it could be in high distress, right? That's when we will want to start to use some of these skills, right? And make sure we're assessing for safety, asking those questions. Are you having the thought of hurting yourself right now? Okay. There's a lot of different safety interventions we can use. Biggest one is making it speakable, right? And we had already discussed some ways you can do that. If you forget all of this, okay, let's make it speakable. We can also have safety plans. And this is something that kids can write down in a formal or informal way. Here are my go-to things that I do when these thoughts start getting so heavy, right? Or when these urges to hurt myself or not stay safe are so overwhelming. Here's what I'm going to do. I'm going to call up grandma. I'm going to drink some tea. I am going to brush my teeth and take a nice shower. It can be little, right? It can be little, or it can be something that's a little bit, more jarring. I'm going to, hold ice in my hand. I'm going to do some jumping jacks, whatever it's going to do, right? Parents can safeguard the environment. I don't want parents to think they have to go and kind of round up everything that's in their home right now. This is really if there's been some of these thoughts, urges expressed, right? If you're having these conversations and you're identifying wow, my child's going to have some tough urges. We might need to collaborate more to keep them safe, right? And that could mean taking out sharps, locking up medications, locking up things that could be dangerous chemicals. And a crisis kit. Like, this can be nice for kids that, are experiencing this chronically or have had history of suicide attempts, right? There's some virtual crisis toolkits like the Hope Box app, which can be really nice. Encouraging kids to hang pictures of people they care about in their lockers, or having a journal where they list their reasons for living, right? Something visible and tangible that can remind, okay, there's hope on the other end, and this is a really difficult thing my brain is putting me through, but I can survive, and I'm going to move through this for these reasons. Okay. Now, we want to be mindful that there's so many things parents can do. Again, speakable, stay calm. However, if you notice your child struggling, remind them of some of those things, right? Safety plan, a stress protocol, right? Things that they've done in the past. If you feel like this is essential and it's just not happening, reach out to a professional, right? See if a professional can work with your child or family to make a safety plan, because sometimes it is difficult to make one with your team, right? See if there's a resource you can pull in. There's also a lot of apps that are helpful. If you notice kids using skills, great, point that out. Sometimes we need to do it in a way that's, really highlighting it specifically. For some teenagers, it's, hey, nice job, I'm really proud of you, right? Keep it simple, and kind of match their tone. And if you're noticing plan and intent, can't say it enough, you are showing love and compassion by getting more support. And it's okay to go to the ER. It's okay to call 911. That's going to connect you with community resources if needed.
Julia?
Yes.
In the interest of time, would it be all right if we skip past the accommodation so I can talk briefly about prevention measures?
That's beautiful. Let's do it.
Okay. One thing that I want to mention, because we see this happening a lot, and I think it's really difficult for parents, that is a picture of a butterfly coming out of a cocoon. And it's to remind you to tell you the story about how, the caterpillar makes the cocoon and becomes the butterfly. If somebody were to come, a helpful person were to come and try and help that butterfly get out of the cocoon by maybe ripping it for them, that some of those butterflies will die, because what happens in the struggle of coming out of the cocoon is the wings get stronger and dry off, right? And if we do that for the butterfly, the wings don't get strong and they don't dry off quite as good, and then they can't use them, and then they get stuck. How does that apply to parents? Well, there's a certain amount of moving things out of the way and making things easier for your kids that is akin to breaking the cocoon for the butterfly, right? There's a certain amount of struggle that the kids need to do. But then also with depression, there's a certain amount of struggle that they don't need to do. And that is an area for, talking to mental health providers or therapists and for the psychiatrists. But I know that people really want to reach in and help. And sometimes there's a balance between, strengthening the wings by helping the struggle and aiding the way. What we really want to do is help people move away the struggle against depression, and then leave the struggle with real life. Sometimes those get mixed up. And one of the things that we see a lot is parents saying that situation X is too important to fail. So I need to help my kid do this, and we don't have time for treatment. And situation X could be all sorts of things, right? This school term, this game, this exam, this performance, this interview is too important for us to mess up, and we can't miss it, and we need to focus on that. And here's the truth about the thing that's too important, is as life goes on, the stakes only get higher. And so what happens is we kind of kick the can down the road by not addressing depression and mental illness early, because we think, we got to get through 7th grade. No, we got to get through 8th grade. No, we got to get through, the exam period. And I want to encourage everybody to rethink that, because you might be able to kind of tape up your kid and get them through this thing. But if you haven't solved that underlying problem, it will come back. Remember, it comes back, and it'll come back at a later time when things are even more important. So I want to encourage everybody to just kind of rethink that. When you're thinking to yourself, oh, we could do it later, ask a couple extra questions about, is later going to be an easier time for my kid to do it when they got to do, when they're in college and they're alone and they're in a dorm. That is one piece of important information. And the other one is, what can we do about it? Here's the thing I want parents to know is this one. So Erin said, our families want to know, what can we do to do some prevention? So I did a quick lid search, and here's the answer. The strongest risk factor for the development of depression in your kids, above and beyond all the other risk factors, is having a parent with a depressive illness. So that the offspring of depressed parents have 2 to 4 times the risk of getting a depressive disorder. Partly it's genetic, but partly it's environmental. When they did one study and they looked at the parents of who were bringing in their depressed teenagers into treatment, over half of them had their own depression. What are you going to do about that? Take care of yourself. Julie and I see this all the time, is that parents are so worried about getting their kids treatment that they forget to take care of themselves first, right? And that's what this put your own mask on first. They did one study where we just treated the depression of the parents, but we followed the kids. And the kids didn't get any treatment, but the kids got better as the parent got better. So you can help your kid out by taking care of yourself. I know everybody's like, I don't have the time, or I got to, right? We're worried about the insurance or the coverage. There are places where you can get affordable treatment. They're hard to find, but you can find them. And it will help your kids. So if I can say one thing to the parents, is make sure that you are taking care of yourself. And then the last thing that I really want to highlight is prevention strategies. So I looked into the data on this, and there's 3 types. There's universal preventive intervention. That means all the kids in school get treatment or education about what is depression and how to manage it. There's another type, it's got the star because this is the one that's the most effective. We select the kids who are at high risk maybe because they have any of those risk factors, including children of depressed parents, and we give them specialized education and treatment and groups. And then the last one is you can wait for the kids to start to show that they have some problems and target them. The selective prevention programs have been shown to be the most effective. But then here's the next tidbit, is that half of adult disorders have onset by age 14. But there's a developmental window between 11 and 15 where the symptoms are present, but they haven't reached a full-blown disorder, which means that we need to start before high school, right? Now we're talking about age 11. Now we're starting in junior high to start to maybe seek out and provide some education for the kids. And then the last slides, I think everybody's going to get some handouts. What can I do if someone I know might have depression? Find an adult, right? The kids like to talk to each other and they don't talk to adults. We want to send the message. The answer is find an adult. If your kid heard from another kid that somebody's depressed, your kid should encourage their friend to find an adult. Your kid can tell you who's an adult. You can talk to another adult. So we want to make sure, even though their first instinct is to talk to a friend, we want to support this idea that we're going to find a trusted adult who can help, and that we don't want to keep secrets. So I know, right, that I'm going to tell my best friend, but my best friend needs to know that keeping that secret is not helpful, and that keeping those secrets is not the way that we should do things. And we want to educate the kids to not keep the secrets and to find an adult. If we have somebody online, right? So this has everything but TikTok. If your kids or you're seeing somebody online who's posting suicidal messages or something disturbing on social media, the first option is call 911. But if you don't know where that person lives, each one of the social media pages has has steps to contact them to report that. So ideally it would be 911, but if you don't know, all you know is this, right? This other kid lives in Kansas, you can contact the social media platforms directly. And so I'll leave those there. And then there's a couple little resources for dealing with teen depression. And I'm going to wrap it up so we can take some questions. Oh, I said we would finish early so we had more time for questions, but we're happy to stay later if anybody has some.
A few very thoughtful questions in the chat. I did just answers, thoughts to those questions there. In the interest of time, I'll just read those out and give brief thoughts so that others can hear them. Someone had asked, what to do, especially for communities of color when calling 911 can be very triggering and difficult. Absolutely. I think that's a very, very valid concern for many communities, especially right now. So one thing to keep in mind is to call a crisis line, which can also talk you through your local resources. If you feel like you can transport safely, if your teenager is in a crisis, you can go directly to the emergency room for a psychiatric evaluation. And if not, being very clear to the dispatcher of what you need, right? My son is, you can say, my son is a large male. He's a senior in high school. He's having a mental health crisis. Here's what it's looking like, and here's what we need, right? Because a lot of times, just information and setting the tone for what's happening is going to help hopefully reduce parents' anxiety, that is very valid, and allow for the dispatcher to inform the responders to what the scene is and what they can anticipate. Someone had asked, if this is different when depression is triggered by the pandemic, right? And certainly we're seeing that it's here with vengeance. We are experiencing high wait lists and high acuity. My thought on this, and Dr. Young can certainly add, is that yes, we're seeing these are the triggers all at once, right? So Dr. Young spoke to the fact that it is often triggered by a stressful life event, right? And there are risk factors that can take someone that's already predisposed to a mental illness like depression and trigger it. So we're looking at things like grief, uncertainty, loss of routine, kids aren't in school. And so certainly, yes, if someone has a predisposition for depression and all these triggers are happening at once, it can absolutely make someone's depression come on maybe quicker than you anticipated or in a more acute or severe way, right? I think that is happening for many people. For all people, I think there is a lot of fatigue being home. And so balancing the difference between, are we all really frustrated and exhausted by the very real collaborative trauma of a pandemic? Or is my teen experiencing depression? And when in doubt, seek support. Go to a local provider, have your teen talk to a social worker at school. There are a lot of resources to kind of parse out, am I really just feeling isolated? Am I stuck? Am I lonely? Or am I experiencing something more like depression?
I'll just say I shook my head at that. Is it the same? Because the depression's the same, right? The depression is the same. The stressors are huge and numerous. So it's more likely to kick off the depressions, and then our options for engaging in healthy activities have been limited, right? So the depression is the same. There are more triggers, and it's harder to find things, treatments to do because the treatment providers are overwhelmed, and it's harder to get your usual mood benefits from doing your usual stuff because nobody gets to do usual stuff. So that's what's making it extra tricky these days, I think.
Absolutely. Dr. Young, someone had mentioned wondering how often the criteria for a major depressive episode needs to occur. And so if that's something you could speak to, they're referencing slide 9.
I don't see the question. Can you read it to me? What is it? How often does it need to occur for?
How often does one of these need to occur for them to count as indicators of depression?
Oh, so that is all you need is 2 weeks where it happens most of the day, nearly every day. So I'd say if you most of the day, nearly every day, it's probably 5 days out of the week for most of the day, and you only need 14 days of that for it to qualify as a major depressive episode. Again, I think when we're looking at prevention, we want to kind of prevent early. So if you've seen somebody that's got a subclinical depression, you might want to address that also.
And we have a question from Joy. Don't you have to take Prozac daily for a few weeks for it to kick in and then take it daily? SSRIs have not worked well for those in our family. Wellbutrin seems to work better since it kicks in immediately and still works. Yes, so SSRIs do need to be taken daily. It's a medication that, kind of builds up in the system. And I always say I'm not a medical professional, but there are some lovely ones out there, and not all of our brain chemistry works the exact same. So really being honest and open, hey, here's what our family has tried, here's what's worked, here's what hasn't, here are the barriers, right? Maybe it's really difficult to remember to take this medication every day. What are my options? Our doctors often say that the difficulty with psychiatric medications is that there's trial and error. And so it may mean that you're just continuing to form a close connection with a provider that you trust, and you can be open with how you're feeling and what's happening, if there's symptoms, if there's side effects, and exploring what works. It's a really difficult but necessary thing sometimes. And then we have one more question. What happens to a child who's being treated with medicine and therapist when they go to college? How do parents keep a good pulse? Such a good question. Something we hear very often.
Would you like to take a shot at that?
Sure, yeah.
Go ahead.
I'm sorry, did you say you wanted to take a shot at it?
I did. Because I've got a practice where I've got a bunch of Northwestern students, and I'll tell you what I've seen that works well is find a therapist in the town where your kid is going to school. Okay, this is pre-pandemic advice, somebody who could see your kid in person. Now that everything's teletherapy, it may be possible to continue with the outpatient providers via tele, although sometimes the therapists aren't comfortable doing that across state lines. So if your kid's going to school in a different state, you may want to consider having set up before they arrive on their first day at campus. So I'm thinking a couple of months early to set up and get connected with a psychiatrist and a therapist in that town. And then the other thing, because they will be adults or be over 18 and they can direct their own treatment at that point. As the therapist, I usually have those students sign a release of information for me to talk to their parents, because the parents are part of the system. So get your kid to sign a release of information so that therapist can talk to you. And then start early, maybe a couple of months before they go to school. You can call the counseling center or ask your therapist for recommendations of the person in town. But I would get that all set up before the first day of school or before they move into the dorms.
Yeah, and something that we often tell parents too is that it is a hard transition. You're going to be living with uncertainty. I am very biased to therapy as a therapist, but it's because it offers a great safe space to process. So for even parents to get their own clinician to talk through the difficulties and stressors of this new life transition for you, and remembering that making some mistakes and being independent and learning how to manage this is going to be a process of your child's development. So making that a goal before they go to therapy, if they do have someone that's been working with them, go to college, if they do have someone that's been working with them, saying, how do we make a goal of advocating for, my child's mental health, something that they're practicing now? How do they know when they need to reach out? How do they know what their resources are, and how can they take some ownership? It's kind of holding both truths. You're always going to be their parent, and knowing what resources you can connect them to, while also empowering them to make these own connections themselves, and to make that a step that they take. Because just as Dr. Young had said, these mental illnesses, depression or otherwise, stay with us. And it's important to know how to empower yourself to help yourself throughout your life.
All right, well, we are only 15 minutes over. It looks like there are no other questions. So thank you to those who stayed on extra to hear the Q&A, and we are so appreciative both to Dr. Young and to Julia for all the great information that you provided. So all of you attendees, be on the lookout for more emails with all of the information so that you can have that accessible later on. But thank you so much for joining us. And again, thank you to Dr. Young and Julia for your expertise on this topic. So I hope everyone has a great rest of the day.
Thanks for having us.
Thank you.